Tēnā koutou katoa, ko Michael Baker, toko ingoa. First of all, I'd like to express my huge gratitude to the Royal Society, to Aparangi, for electing me as a fellow. And I'm just sorry I'm not there with the other new fellows to celebrate this great day for all of us. So as you can see, my presentation today is going to focus on what I think is a critical challenge for research, and that is to produce work that is anticipatory, integrated, and translational. The reason I'm not here with you today is that I've started my Fulbright Fellowship as a visiting scholar at the Harvard T.H. Chan School of Public Health in Boston, which I'm greatly enjoying. So it's always a challenge to make sense of the last 30 plus years of your life. And I've always been taken by this quote from Kierkegaard, who talked about the idea that you must live life forwards, but you can only really make sense of it backwards. And I think there's a little bit of that in my presentation today. So it's probably an understatement to say that we live in challenging times with more complex and interconnected global risks, and that we're not sufficiently prepared. So this is where I think we need a research response that is appropriate for these kind of challenges. And my argument today is that we need more research that is anticipatory, so it drives prevention. It's more integrated, so it considers the wider context, the causes and consequences of events, and that it's translational, so that it is communicated effectively and impactful. And today I'm going to give some examples from my own work to illustrate these research principles. So anticipatory research, this is an example that actually started me in my focus on population health. I was a clinician in Auckland, and I was offered a short-term job working in the Beehive for a Minister of Health as a medical advisor. At that stage, there was huge concern about the HIV/AIDS epidemic, and also the problem of spread amongst people who inject drugs. And I was asked to go away and research how we should respond to this. And I didn't even call this research at the time, but I was looking at the literature. I was talking with people in the sector, and it was very clear we needed a needle exchange program. So injecting drug users didn't have to share needles and syringes. So fortunately, we had a progressive government, and this measure was adopted by both sides of the House. And New Zealand became the first country in the world with a national needle exchange program. And this graph shows the subsequent 40 years and the fact that injecting drug users have only been a tiny proportion of our HIV/AIDS cases. Jumping ahead more than 30 years, at the start of 2020, we could see we were going to have a global COVID-19 pandemic. But then there was evidence coming out of China that this virus could be stopped. That was in February 2020. And so I became a major scientific advocate for the elimination approach. And this was, in fact, the path that the government adopted. And we wrote what I think is the world's first published elimination strategy for this pandemic. And we've subsequently tracked this, the impact of various response strategies for the next few years. And what we can see here, for instance, is that 3.5 years after the start of the pandemic, New Zealand still had essentially zero excess mortality, the lowest amongst the high-income OECD countries. And if we take a counterfactual analysis, if we'd had the mortality experience, say, of the United States, we would have had almost 20,000 deaths at that point. So looking at the area of integrated research, in the early 2000s, I was very concerned about the rising campylobacteriosis epidemic in New Zealand. It rose hugely over a 20-year period. And at that stage, we looked to see what was associated with this increase, and it correlated perfectly with the rise in fresh chicken meat production. So we wrote about this issue based on the epidemiological and other evidence, and suggested that there should be a huge reduction in allowable Campylobacter levels in fresh poultry. And this policy was implemented, and in 3 months we saw a halving in our rates of this disease, including hospitalizations. So subsequently, I've just finished leading a 5-year Health Research Council program grant on syndemics. And syndemics, this is the idea of overlapping epidemics, making the resulting epidemic worse. And the classic example is HIV, making TB a far more serious disease in parts of Africa. And that's where the idea of syndemics came from. We've updated this concept to take a more strengths-based approach to how to use the concept of syndemics. And we've worked closely with Kokiri Marae in Lower Hutt and set up this program of work. And this is our opening hui, and then a hui more than 5 years later, where we were discussing the results of this work between ourselves and staff of the Marae. So this is the overall framework we were using, how communicable diseases through multiple pathways cause non-communicable diseases, and they in turn make us more vulnerable to communicable diseases. And all of these, this creates a vicious cycle, but all of these pathways can be interrupted with various interventions, and that's what we were focusing on investigating with this program. So this is another syndemic disease. That is how acute strep A infection can cause rheumatic fever, and that progresses to serious rheumatic heart disease. And we've done research at all of these different stages to identify evidence-based interventions, some of which are now being rolled out and evaluated. Another aspect of taking an integrated approach is looking at surveillance itself. And this is the idea to move away from just looking at the end stages of disease and outcomes, upstream to hazards, determinants, and interventions. And we think a more integrated approach to collecting information is very helpful if you want to reduce the burden of these diseases and reduce inequities. So translational research, one of my major activities in the last few years has been setting up the Public Health Communications Centre, which has now been running for 3 years, hosted by the University of Otago in Wellington. And it's fully independent because it's supported by a bequest from the grant to Marilyn Nelson Trust. And this aims to increase the reach and impact of research in New Zealand. We evaluate what we're doing very closely, and this is showing how briefings we're putting out are trying to impact the policy process right around this cycle, from agenda setting right around to evaluation, although I would like to see much more work going into evaluation in New Zealand. Each of these briefings gets an average of more than 6 media items, so that is showing that it's actually a very good translational tool, at least to the point of getting this evidence into the public arena. So my conclusions are that we are in a times of where we have major global and national challenges to health and well-being. And we do need research-informed responses to these threats. I think that New Zealand has a very positive history of highly effective anticipatory research and responses. We are also very well placed to do highly integrated research and interventions because of our small scale. But this research does need to be impactful and well communicated. I really want to acknowledge my many collaborators across the two main groups that I'm currently directing and the wider symbiotic program that we're just wrapping up now. And also my collaborators, particularly in Hei Kainga Oranga, the Housing Health Research Program led by Professor Philip Allen Chapman, and the Shivers team led by Professor Sue Huang, and also my network of researchers in the rheumatic fever area. I also want to just acknowledge working in a very supportive Department of Public Health and multiple funders, particularly the Health Research Council, who've supported this work over many years. Thank you.